Ladies and gentlemen, good afternoon or good morning for those joining from the United States. And thank to Professor Dan Perry. Thank you, Dan, for being here and allowing us to provide families with an option to have an understanding of Perthes disease, but also to ask specific questions with regards to Perthes and the current situation with COVID-19. My name is Loredana Gwich-Wyatt, and I'm the Managing Director of STEPS. For those of you that do not know who we are, STEPS is the leading charity of lower limb conditions, and we support families and adults with a variety of lower limb conditions and also covering soon trauma. If you have any questions, for those of you that have joined through the phone, you can submit them to info@steps-charity.org.uk. This webinar is recorded and will be made available within a few days on our social platforms and YouTube. I think I'd like now Dan to introduce himself. Dan, over to you.
Thanks very much. Thank you for having me. So I'm Dan Perry. I'm a consultant children's orthopaedic surgeon. I work at this place in the background, which is Alder Children's Hospital, which is in Liverpool. And my interest is, I've got a funny life. I spend half of my week doing surgery and doing looking after children. And the other half of my week I spend doing research. So I work with the University of Liverpool and the University of Oxford, where I do a lot of studies into different childhood diseases related to orthopaedic surgery. And my main interest and the reason that I do so much research is because I'm fascinated by Perthes disease, which is where I started doing my PhD about 10 years ago. And so I treat lots and lots of children now with Perthes disease. For some reason in Liverpool, we've got quite a high amount of Perthes. We get about 1 new case every week. So I've really got a passion for treating it and a passion for trying to find out the best way to treat it. And hence why I'm here. So should I kick off by doing a brief talk, just take you through some slides about my understanding of Perthes disease? Is that okay, Loredana?
Yes, please do go ahead. You can share your slides now.
Let me share this and let's not do that because that's the end. You don't want to see the end from the start. Okay, so this is me. This is where I work. This is my Twitter handle, if anyone does Twitter. So this is Perthes disease, and this may be what the x-ray of some of your children looks like. This is a nice round hip, a nice football-shaped hip. And this is a hip where the top of this hip bone is squashed down, and there's some cysts, so some changes around here. And so basically this is Perthes disease. The whole hip is squashed and looks a little bit unhappy. And the question that we've got is how best to treat that, how best to manage that. So what do we know about Perthes disease? Well, if I had to make a guess, I'd say that your child is probably a boy. And they're probably a boy between about 4 and 8 years old when they got it, because that's what the epidemiology, so the background to the disease, tells us, that there's about 4 boys affected for every girl. And the key age of onset is between 4 and 8 years old, typically. The reason we think it happens, so it's important to have a little bit of understanding why we think it happens. So this is a hip bone. This funny white line here is the growth plate. And this funny line here is the blood vessels. And so for some reason we think between 4 and 8 years old there's a single blood vessel which feeds this hip, and it's all a bit peculiar really. But this blood vessel's got a fancy name called the lateral ascending epiphyseal artery, and we think that this gets blocked off. And because this gets blocked off, this means that the top of the hip bone can't get food anymore, so it can't get all the nutrients and all the goodness it needs, which the blood brings. And therefore it turns squashy and it dies. And that's essentially what happens in Perthes disease. This bit dies, and over the course of time, it gradually comes back to life. But when it dies, if you imagine this is like a freezer cable, and so this is just a big ice cream, and so this is completely solid when the freezer cable's working. But if you turn the freezer cable off, then all of this ice cream on top melts. So the ice cream's still there, but it becomes very soft and very squidgy. And that's the trouble with Perthes disease. All of this is soft and squidgy, so the hips very easily deforms as it goes through normal life. So what else do we know about Perthes disease? So we know that Perthes disease, for some reason, affects people in the north of England more than the south of England. So this is some work we did a few years ago now. We show that London's actually got relatively a small amount of Perthes disease, but where I work in Liverpool and further in Scotland, there's lots of Perthes disease, and that's peculiar. And Northern Europe, but in particular England, has got huge amounts of Perthes disease compared to anywhere else you go in the world. So it's a really interesting disease, and that's partly why I'm so passionate about it, because it's something that really affects the children that I treat and I see about day to day. The good news is it seems to be decreasing. I know that's not necessarily good news to you guys who are suffering it, but on the whole, it's decreasing, and it's back about 20 years ago, it was about 1 in 700 children have it. I know you'll read lots of different things about the number of kids that have got it, but it's actually about 1 in 1,200 is the lifetime risk of having Perthes disease at the moment. So it's certainly fallen. So one of my great mentors, Colin Bruce, who works with me at Alder, used to teach me that the anatomy of kids with Perthes disease is a bit like Bart Simpson in a way, because the kids tend to be the shortest kids in the class. So they're quite short children, and we don't really know why that is. They tend to be a bit hyperactive, so they tend to be a bit all over the place, and they're usually white children. So it doesn't tend to affect. It affects other racial groups far less than it does white Northern European children. So he used to describe it to me as Bart Simpson. So I'm sorry, but that's the way I've kind of got it in my head. We talked about hyperactivity just, and there's lots of talk about whether hyperactivity affects is related to Perthes disease, and we know that the kids are often a bit hyperactive compared to their peers, and there's some theories which suggest that because they're so hyperactive, they put a lot of force through their hips, which may give them the Perthes disease. And then there's other theories that say, well, perhaps because they've got the pain, that's what causes and that's what makes them a bit more hyperactive. And we're not sure about which way round it is, but certainly they are a bit more hyperactive than other children. So we know that on the whole, they're short, they're hyperactive, and some have had genitourinary abnormalities. So some have got hernias around the groin or an undescended testicle or something else going on. Not all, it's a small percentage, but that's kind of the association. So a small amount have had some problems around the genitourinary, around their bits in the past. So lots of parents ask me, is it genetic? And so to look to see whether it was a genetic, we looked at a big twin registry in a twin registry called the Danish Twin Registry. So we have to do it properly. If it's a Danish twin registry, we need 2 pastries. And the reason we looked at that is we tried to look at identical twins and non-identical twins with Perthes disease. And therefore, if it was a genetic disease, if you've got 2 pastries, they'll share, if you're identical twins, they'll share 100% the same genes or the same pastry. And if they were non-identical twins, then they'll share 50% the same genes. And so we looked at this and we found 81 twins of whom at least one had got Perthes disease. And from that, we could show that there was no strong genetic component of Perthes disease. So we don't think it's a genetic disease, but it does happen a little in certain families, which sounds a bit odd. But it's not genetic, so it's not something in the genes that's causing the Perthes disease. But we think it's an environmental factor, so something about perhaps the way the family eat, or something about the in utero environment, so before the child's born, that makes it slightly more common. And when we're saying slightly more common, it's very, very slightly more common in certain families, but that's not a genetic tendency. So you may find that an uncle or a cousin had Perthes disease, but it's not truly genetic. One of the big problems with Perthes disease, and I'm sure one of the big issues that you guys have got, is if I list the treatments for Perthes disease, it's huge. So there's treatments like conservative treatment, where we simply observe the disease. There's spiky casts, different sort of casts, muscle releases, different sort of forms of hip osteotomies, different forms of pelvic osteotomies. It's really, really, really confusing. And it's confusing for everyone. one of the difficulties is that when there's so many treatment options, it almost shows the level of uncertainty there is in the medical community about how best to treat this disease. And I'm afraid that we as doctors share your uncertainty, and we're desperately trying to make that more certain at the moment by trying to do better research, because in the last 100 years since Perthes disease was first described, the research isn't really as good as we'd like, and we're really trying to take the bull by the horns at the moment, both here in the UK at the moment and also in the US, to try and improve that research. So I know that doesn't necessarily help you, and I'll try and help you through this. But there's loads of uncertainty around which treatment's best. And the reason we treat it, so we've talked about this. We've talked about this is the ice cream and this is the freezer cable, and for some reason this freezer cable gets turned off. What we're trying to do is to keep the hip in a nice round shape and stop it squidging and squashing out of place to make a weird shape. And so all the operations that we do try and change the environment so the whole of the hip stays in the nice round socket, because the nice round socket is a nice round mold. So I want to do everything I can to try and put this hip inside that round mold and stop it squidging out, because we think it's the squidging out that causes the problems. And of course, the problem is that if it came back to life in the squidge position, then you wouldn't end up with a football-shaped hip. You might end up with a rugby ball-shaped hip, or you might end up with a hip that's a really weird bulgy shape, which obviously wouldn't work like a hip then. And in that situation, the child's going to get very severe arthritis very early, in the worst case scenarios, and that would be a pickle. So and obviously cause them a lot of pain, and may mean they need an early hip replacement. So that's what we're fighting against. In the very old days, this is how they were treated. So this was sent to me by a very kind chap in Yorkshire, and I think he was this guy. But in the olden days, they were treated for 2 years in Bedrest, so in hospital for 2 years, which I believe from this fella didn't really make much difference, because as soon as the nurses turned their back, the children were wild and out of bed. But that's just gone to show how treatment has changed over time. And then these are some of the other ways that children are treated in different forms of caliper or with surgery, either on the femur or the socket. Most common operations I do is either what's called a varus osteotomy, which is where I break the hip here and try and tuck this outer part of the hip inside the socket to allow it to regrow as it regrows in a nice round shape. These hips always regrow, but often they take a few years to regrow. Or in slightly older children, I do an osteotomy on the pelvis. So I add what's called a shelf to the edge of the pelvis to try and stop this part squidging out as it's soft. And that just keeps it nice and in the right position. So as it regrows in a nice spherical shape rather than a squidge shape, which wouldn't work so well. So that one's a shelf osteotomy. So, but my big questions, and the questions that I can't answer, is as a surgical community, we're not terribly sure how much surgery helps. There's some suggestion about how much surgery. There's some rudimental research which suggests surgery might be helpful, but there'll be lots of uncertainty about who does surgery and why they do surgery, and that's just because there's been no really good studies. So what we need to do is a study of surgery versus best conservative treatment. So the best physiotherapy and observation and whatever we can do that isn't surgery. But I need to know, would parents be prepared to be part of a study? And I need interested parents to help me to inform the design of that. And I've already got some from my care, but I'm opening up to you and STEPS because I'm really keen to have your input as well. So that's me. We've just recently finished a big national study about Perthes disease, which has got about 500 cases from the UK, and that study is just about to report in the next couple of months. So I'll be keen to share that with STEPS over the next couple of months. But I'm really keen to answer any questions and keen to have you guys help me inform the future research. Thanks.
Thank you. That was very informative, and we do have some question already come in, but for those of you that have not been able to submit your question, can you please send it now as we're entering the Q&A session. I think somebody was commenting that it was nice to see the comparison with ice creams. I guess probably I want to start with the first question that we discussed previously before going live, related to adults and Perthes. Would you be able to explain the difference between Perthes disease in children and Perthes disease in adulthood?
Sure. So Perthes disease is a disease of children primarily. So what happens? And I've got props. This is the hip joint, and so the blood vessel comes up and blocks off, and so this part of the hip dies. But I'm disappearing. But the top of the hip always. Should I turn my background off? That's not. I just move on. The top of the hip bone always comes back to life, but as it does so, it may come back in a slightly odd shape, and so this is a hip that's more of a mushroom shape than a real round shape. Sorry, this background is gonna annoy me more than anyone else. So let me get rid of this.
You're disappearing. There you are.
So this the top of this mushroom, a mushroom hip doesn't really work so well, and so this hip is gonna form very early arthritis and begin to wear away very, very quickly because it's not articulating, so not in the socket as it should be. And so in Perthes disease in children, we're trying to change the way that the hip regrows, whereas in adults, the hip's already regrown, so I can't influence the way it's forming. And so we really need to just make the best we can of the position it's in. And so in children, I might do osteotomies to try and so I may break the bone or do things to try and influence how we treat and how we regrow the top of the hip bone. But in adults, the only thing I can do is give painkillers. That there is some operations that we can do to try and cut bits off of the top of the hip bone if they're causing a particular problem. But ultimately, the ultimate operation for adults is to replace the hip. Whereas as kids, we're trying to do lots to influence how the top of the hip bone regrows. Did that help?
Okay. Yeah. No, I think yes. I'm looking at the coming in and saying that definitely answered the question. Moving back to Perthes disease in children, and specifically with COVID-19, there are a lot of parents out there that they're quite concerned because obviously surgeries have been delayed, postponed.
Sure. Yeah.
The first question that has come in is basically related to whether Perthes disease is deemed as a high-risk condition with regards to COVID-19.
Yeah, no, it's not. So there's, it doesn't increase our as far as we're aware, it doesn't increase our risk of anything else, related to COVID-19, or respiratory illnesses and things. Okay. And I completely understand that's a very stressful time. And as a surgeon, it's completely changed the way that we work. And I understand that you as parents are all anxious about, how that may affect your child's care. But I think, if I'm honest, you're far safer not being in the hospital at the moment. I think you're safer just waiting till the COVID is finished, and then waiting to go ahead and do the surgery when it's much safer in hospital. At the moment, hospitals are a scary time for us, and really no one wants to be there.
Thank you, Dan. And I guess this is the concern of a lot of parents, is basically understanding, is there anything they can do while they're waiting, or is there anything they shouldn't ask their children to do if they're waiting for surgery?
Yeah, it's very difficult, and one of the big difficulties that parents have got is that we surgeons all give slightly different advice to different people about the level of activity that children can do. I don't want to give any individual advice or anything, because I don't know all of the children that are a part of this. What my advice to the children that I treat tends to be is to avoid bouncy castles and trampolines, because if the top of this hip bone is squidgy, then I can imagine that lots of repetitive movements to squash this down is not necessarily going to be a good thing. But I'm also aware that children need to go out and play and have a normal life and just be children. So I tend not to restrict their activities in any particular way beyond avoiding bounces, castles and trampolines. But I'd like you to talk to your individual surgeon, your individual team about, how best that they want that managed.
Thank you, Dan. I guess the message here is if they have any concerns, and due to the fact that every surgeon obviously has a different approach and might have a different approach, is for them to go back to their medical team and discuss their concerns with the medical team.
Sure.
Okay, thank you. With regards to, I guess, children that are active, or especially those that swim a lot, because there are studies that suggest that swimming is good for Perthes. It's not just for Perthes, but for hip dysplasia as well. Now, there are some children that were quite active in swimming, and now everything has come to a stop and they're not active at all. Is there anything, is it damaging now, potentially long-term is there potential damage from the fact that they're not active, or is it fine if they're not doing those activities?
If I'm honest, I think it's probably fine. I think that, so obviously we want lots of active movement, because all the time I want that hip to be moving nicely in the socket, because when it's a soft squidgy ice cream, lots of good movement in the socket is a good thing to keep it smooth and keep it nice. But I think as long as your child's not overdoing it, I think if they're playing in a garden or wherever they may be, kind of having their energy at the moment, I think that's a good thing as long as they don't overdo it. I think if it becomes very stiff and very sore, then that's the time to let them, encourage them to ease it and don't try and push through the pain in Perthes disease. Because when Perthes disease hips get very stiff and sore, what tends to happen is that's when they tend to start kind of edging their way out, and that's where the socket starts to dig into the edge of the hip. So in those children, I tend just to rest the hip for a couple of weeks or days or weeks, however long it takes them to get better. Because at least in my mind, what's happening is the hip is then sinking back into the socket, and it's just easing off. So don't try and push through the pain in Perthes disease. If it's sore, I know it's difficult, but try and encourage your kid just to rest for a wee while. But that's hard. I've got a 7-year-old and a 3-year-old. I completely get the challenges with trying to make your child rest.
Indeed, it is quite difficult, especially when we're in lockdown.
Absolutely.
With regards to, I guess, treatment, I can see a lot of questions coming in. When do you start to treat a child, and how long might it take to treat a child?
Sure.
Yeah, sorry, I'll ask the second part of the question.
So the top of the hip bone, so I said it always regrows, and it always regrows over the course of about 3 to 5 years. So in the youngest kids who've got mild disease, it will take about 3 years. As you get older, so by the time you're 8 with Perthes disease, you're already getting quite old. And those hips take longer to completely regrow. The treatment, it's really, really hard to advise on treatment, because it's really dependent on the beliefs of your surgeon. And ultimately, you need to find a surgeon or a doctor that you trust, and buy into what they're offering you, because everyone does something slightly different. If you're going to do surgery, then the evidence from India, from a guy called Benjamin Joseph, suggests that doing surgery earlier in the disease is perhaps better than waiting until the hips already squashed down, till the hips collapse before you do surgery. So there is some evidence to suggest that doing surgery earlier is good, but again, it's not good evidence. There's no really strong evidence in Perthes disease, and that's what me as an academic, that's what I'm trying to build.
Okay, thank you. And I can see a lot of people answering your previous question to your previous call to say whether they would be interested in taking part in research, and many are actually saying that they would like to participate.
No, that's great. Thank you.
I'll surely try. I will do my best to put them in contact with you.
Okay.
With regards to Perthes disease, I can see from the Q&A questions, they're wondering whether is this something that does go away, or does it stay with you until adulthood? And does this lead to potentially hip replacement?
Yeah, so it very much depends on what happens with Perthes disease. So if the hip stays in the socket and it regrows in a beautiful round shape, and you end up with a hip that looks beautifully normal like this, then you're not going to end up with any problems at all. You're going to end up with what is essentially a normal hip joint that lasts until normal adulthood. So it might never wear out, or it might wear out when you're old. Whereas if the hip regrows in a funny shape, so I don't know how well you can see this, but this hip's are kind of squashed. It's not very round anymore. It's more like a mushroom than it is a round ball. So these hips wear out much faster. That's not to say that they're going to cause pain straight away. They still might last into their 40s or 50s, and the people that have these hips still might live very active lives, but they're likely to wear out a bit sooner than a normal hip. So Perthes disease does kind of the effects of Perthes disease do go on into adulthood, but the Perthes disease itself finishes once the hip has regrown. So when the hip's regrown, then it's not really Perthes disease anymore. Then it's an odd-shaped hip. But the Perthes disease that I treat is when the blood vessel, when the top of the hip bone's still soft, and when I can influence how it rehardens, how I can try and influence the shape of it whilst it's rehardening.
Okay, thanks, Dan. And I guess probably with regards to we talked about the older children and I can see that some here from the Q&A questions, some already had a hip replacement. They're saying that they still have pain, and how do you manage pain, in cases where you have had a hip replacement at a young age?
So that's very challenging, and I'll be completely honest. I don't treat any adults, so I only treat children. Obviously, a hip replacement is one of the best operations that we do as surgeons. So the best operation, according to the World Health Organization, is a cataract operation, and the next best operation is a hip replacement, because those two operations hugely change your quality of life and can take someone from being what could be quite disabled to being basically normal overnight. However, hip replacements don't work for everyone, and some people still may have pain or discomfort afterwards, and that may be due to the hip replacement having a problem, and in which case you need to speak to your surgeon and work out if there's any infection or anything else in the hip replacement, or it may just be one of those things that is really difficult to get on top of, and then it'll be working with your local pain service or whoever can help you managing that pain. But it is a difficult journey, and we all appreciate that.
Thank you, Dan. I'm conscious of time is already 1:30, and I have received quite a lot of questions, so I'm going to go through the most relevant. With regards to pain and children, we do have quite a lot of questions on that. So children that don't have surgery or are not scheduled to have surgery, and so it's more observation, but sometimes they have pain. What do you usually recommend these children have in terms of pain management? Yeah,
it is very difficult. Obviously paracetamol, so Tylenol for anyone in the US. So simple analgesics. So paracetamol and ibuprofen, as and when the child needs it, are very safe and are effective if they're taken regularly. Beyond that, it's really challenging. So I tend not to give any opiates, so not to give any morphine, because I think that's just, for me, that's just one step too far in Perthes disease. We know that the first year of it is going to be the worst year, and I know that when your child just come to me and firstly with Perthes disease, I know you're going to be going through a tough time, and I know over the course of the next year or so that it's going to get better. You may have periods during that time where just as you think it's getting better, you take a big step back, and that's kind of normal. So often I'll get parents phone me and say, look, it was getting so much better, and then suddenly we've taken a step back, and that's all part of the disease just sorting itself out, and it's almost like a stepwise change as it gradually gets better. But beyond paracetamol and brufen, I don't think there's anything that we can really do except to give it time. And I know that's hard.
Thank you, Dan. And there's also here from the Q&A session a question that has appeared several times. Children diagnosed with hip dysplasia and then later on developing Perthes disease.
Yeah.
Are they associated somehow?
Oh, so that's interesting. So hip dysplasia, so DDH, developmental dysplasia of the hip, is very typically in girls. So true hip dysplasia is probably about 10 times more common in girls than it is in boys, whereas Perthes disease is about 5 times more common in boys than it is in girls. So they're kind of, the two diseases in a way don't necessarily seem to be related. What can happen in DDH, so in hip dysplasia, is when the hip's put back into the joint. So if the hip's been dislocated for a long time, let me use a different hip. So if the hip's been dislocated for a long time, as it's put back in the socket, the top of the hip bone can be squeezed as it's squeezed back in the socket, and that can squeeze the blood out of the top of the hip, and that can start a process called avascular necrosis, where the top of the hip bone loses its blood supply and dies. And so in a way, it's like Perthes disease. It's a similar process to Perthes disease, but the actual reason for it losing its blood supply is different. It loses its blood supply, we think, because it's kind of been squeezed and squashed in there, whereas in Perthes disease, it's more about this blood vessel getting blocked off for some reason. So both can result in avascular necrosis, but the reason we think it happens is slightly different.
Okay, thank you very much, Dan. I think probably we will have to schedule another webinar based on the number of questions we are receiving, which I suggest probably we'll talk about and probably organize next week, Dan. I would say for those of you that still have questions, to send it to info@steps-charity.org.uk, and we're going to organize another webinar given the number of questions that we are receiving, and we're obviously not able to cover all of them now. I know that some of you again are sending questions related to how can we join these research programs, and what I suggest is that can you get in contact with us. You have my email address, loredana@steps-charity.org.uk, and we're going to pass your details to Dan. Yeah. So for now, I say thank you, Dan, very much for joining this webinar and for your clear explanation. Much appreciated. I'm sure that a lot of parents are reassured by what you said today. And for you, families and adults, if you have any question, please do contact us. We do have a helpline, and we can put you
just to say thank you for having me, and just to reiterate, like, we understand that your children are really, really important, but in the NHS at the moment, with COVID, it's a really, really tough time. So please, please try and bear with us and give our secretaries and all of our, all of the people that help us do our work, to just be considerate for them as well, because we're all having a really tough time. And so yeah, we'll look after you the best we can, I promise you.
Yeah, thank you, Dan. You're absolutely right. The key message here is that at the moment we're going through quite a difficult situation with COVID-19, and the advice is not to go to the hospital. It's better for your children, it's better for you, but we do understand that you're concerned, and that's the reason why we're organizing this webinar. But most importantly, we're still here. The health professionals are still there. You can contact them via phone. Some of them also provide capacity to do video calls if you're concerned. Basically, do contact your health professionals, and by all means, if you can't, come to us. We'll try to answer your question, but every case is specific, and also with Perthes disease, there is no one way to treat a child, as Dan has outlined today. So, and it's quite important to understand that what works for one child does not necessarily work for your child, and please refrain from looking at general advice that is provided on several groups. Always go back to your health professional team. Well, with this in mind, and I'll thank you, Dan, and all of you for participating, and until the next webinar, thank you very much. Bye-bye. Bye, everybody.